This problem of the indicated remedy not working is a common one, even for the best and most experienced prescribers. And, you know, one shouldn't blame oneself too much, because a lot of it is due to the inadequacies of the homeopathic materia medica. You know, frankly, I better not alarm you too much, but when you look at it too closely, you realize that a lot of the data is out of date, of dubious provenance, and all kinds of other problems. I mean, Kent's Repertory, last edition was 1904. Of course, it has been updated somewhat subsequently, but the original data in Kent's Repertory, basically we don't know where it came from. And certainly it was gathered in completely different diseases from what we're now treating. I mean, Kent was treating you know, mostly acute bacterial infections. And that is now a relatively minor problem in modern medical practice, because, you know, they all get zapped with antibiotics before they get anywhere. On the other hand, we're dealing much more with chronic disease, psychosomatic disease, iatrogenic disease, and so on. So we have an entirely different pattern of disease. And in any case, you know, there are, without going into too many details, there are, you know, problems with the provenance and the reliability of the data that we use. That's something we're working on. But what I want to talk to you today is something very pragmatic. You're sat there, the patient is over there, you saw them, this is the second appointment, you prescribed a remedy that you were reasonably confident would help, and the patient's sitting there saying, well, I'm no better, doc. What do you do next? So first thing is, don't despair. And of course, one of the sort of classical answers, what do you do? Well, you prescribe a nosode or a miasmatic remedy. That's the sort of, you know, reflex answer that you'll get from some of the homeopathic books. But I think that's, you know, before you think about that, you need to think about a lot of other things. So I would certainly not say, you know, don't jump straight to a so-called miasmatic remedy or a nosode. And the first thing is the patient actually complying? Nothing more irritating than to sit there for half an hour retaking the history and asking the patient all kinds of questions, and then at the end of it the patient says, oh, you know, doc, the day after you gave me those pills, I dropped them on the floor and the dog ate them. You know, that kind of thing. Patients, you know, they may have dropped them or lost them. They may have thought they got an aggravation and stopped taking them. Their neighbour may have told them something which frightened them off. Critics who go on smoking, patients with osteoarthritis of the knees who, you know, can't or won't lose weight. You're on a sticky wicket. You're not, you know, going to get very far. And, you know, very often this sort of thing, you know, betokens a resistance to treatment. They don't really want to get well. And, you know, as you know, patients can have complex reasons. Diseases very often have secondary gain. Somewhere along the line, you know, they find it quite convenient to be on. So, you know, there may be reasons buried under that they don't really want to get better, and clearly that's not going to help. But of course, you know, various kinds of lifestyle things are, you know, you're not going to do very well in, as I say, patients with bronchitis who won't stop smoking. And then other sort of confounding factors. Are you just, you know, seeing the patient too soon? Is it just too soon for a response? This is the sort of rule of thumb that we have, the rule of 12, you know, it's a very approximate rule, but it's sometimes worth telling patients, you know, that, you know, to give them an idea of, you know, you're not going to cure them overnight. So don't draw conclusions too soon, and it may indeed, you know, be confusing to see patients too often. It may be a mistake. You may just find yourself chopping and changing the remedy and never knowing quite what's going on. And in chronic diseases, patients who've had, you know, the disease for years, I would see them, you know, provided they're in the plateau phase, provided they're not in an acute flare-up, every 6 weeks minimum, usually 2 months. 2 months it would be the routine. 2 months for the first appointment, then maybe 3 after that. If you're doing okay. So don't draw to conclusions too soon. And I say you can confuse yourself by seeing the patient too often. And then other things, for instance, you know, it's not that uncommon to see eczema patients who you ask, how's their eczema? Oh, it's the same, doc. But in fact, they've, you know, dramatically reduced their betnovate. So that clearly is an improvement. and perhaps that's just a misunderstanding. You know, their eczema is the same, but their requirement for medication is much reduced. So that is clearly, you know, going in the right direction. So make sure that you are understanding the patient. And then, of course, you know, something which is, of course, I'm sure very familiar to general practitioners, you know, that, you know, really, they're presenting with, I don't know, pain in their knees or whatever, but really the problem is psychogenic. I can give you a little example. A woman I saw, Indian woman in her 40s, who I saw a few months back, this peculiarly Indian syndrome of pain whole body, you know, pain everywhere. You really couldn't find a place that she didn't complain of pain. And clearly it was non-physiological. It really didn't fit in with any known disease, and examination was pretty unremarkable. And, you know, my heart was starting to sink at this point. And, you know, what caused it? Oh, well, she thought she was working in a damp factory at the time. Not a very, you know, not a particularly interesting thing. So we went on talking. So I tried not to get despair, and we chugged on through the history. And it got to the social history, and how many children she had? Oh, well, she used to have 3, now she has 2. Oh, what happened to her 3rd child? Murdered. It was her daughter murdered by her husband 3 years ago. And in fact, almost precise coincidence with the onset of symptoms. And what's more, I mean, it even got more complicated than that. The children, the grandchildren, the patient hadn't seen since the murder because they didn't approve of the, you know, there was a sort of caste issue in there, but they obviously never had approved of the son-in-law, with very good reason, as it turned out. And they had never seen the children since the day their daughter died, and he was also going to come out of jail fairly soon, and so on. So that was quite interesting. And what was very interesting, I think, and we'll talk about that later, was her extreme reluctance to make the connection. You know, she really didn't. I mean, when she was out of the room and getting undressed to examine her, I spoke to the husband, and the husband had no doubt about it, that was the triggering factor, and it was quite clear from talking to her, I mean, that they had both her symptoms and this terrible thing had happened 3 years ago. But she didn't want to make the connection. She didn't volunteer it at all. I only sort of picked it up incidentally. So, you know, and that obviously influenced the treatment. But finally, well, not finally, but let's, you know, assume that, you know, that it is not a confounding factor. It really is the wrong remedy. So, what are the causes of that? Well, I think, you know, there is a real thing of trying to be too clever, or of perhaps, you know, we should perhaps broaden that out and say being too clever, or believing cliches, or something like that. You know, it's quite easy to latch on to some, you know, a single rare, strange and peculiar symptom and really try to prescribe on the basis of that. It's a mistake, nearly always a mistake, to latch on to a single symptom, no matter how rare, strange and peculiar it is, to the exclusion of the broader picture. Always, you know, if you've got a broader picture that suggests one remedy and one symptom, however rare, strange or peculiar it may be, that suggests another, I would always go for the broader picture. So, you know, you may look through your, you know, repertory and find this you know, wonderful symptom with all kinds of modalities, but, you know, don't be tempted too far, at least, to chase off down that particular, you know, blind alley. And what I'd say, one should perhaps extend it. I would also say, you know, believing cliches. And I can give you quite a nice example. Roberto was there yesterday. He saw one of these. About 3 months ago, I was referred in this hospital, by a colleague in this hospital, a young black man in his 30s with a nasty, aggressive inflammatory polyarthropathy. Not quite clear exactly what type, actually. It wasn't clearly rheumatoid, it wasn't clearly lupus, but there was no doubt. I mean, he had a large number of very inflamed joints, you know, and no doubt he had a nasty arthritis. You know, he was, say, young, fit. Threatening demeanor would be perhaps, you know, putting it too strong. He was a bit of a Mike Tyson lookalike, cropped hair, you know, sort of stubbly beard, on examination very muscular, and quite a sort of, you know, hard man feel about him. And, you know, complaining bitterly of this pain. And so we chatted to him, and I said, well, how do you react, you know, when you get this pain? Do you get irritable? Do you chuck things around the room? No. Bursts into tears, cries, weeps. And I confirmed this with his wife. And also strange migrating arthritis. I give him pulsatilla. You see, and the thing is, you tend to think of pulsatilla as a woman's remedy for one thing, and certainly his rather, tough guy, come on, wasn't the pulsatilla thing at all. But the thing of crying when he's in pain, which is very much out of sync with his general character, and also the migration. He came back about 2 weeks later, dramatically better, really very much better, and I'm confident that it will resolve completely. It's very important in homeopathy to have great flexibility of mind. There are different strategies and different strokes work for different folks. You may want to do high constitutional prescribing, you may want to do low pathological prescribing. You have to keep this flexibility of mind. You mustn't get stuck into a rut. Take the history again. Look for correlative alternating features. That's to say, advanced disease may be relatively featureless. Patients with severe eczema, shall we say, they have a rash all over and it's itchy, and there's often not a lot more to go on. So it may be useful to look for correlative features, other symptoms that are present in the same patient. Maybe this patient has migraine, or I don't know, rhinitis. I mean, the rhinitis would be relatively less interesting because, of course, it's an expected association. Rhinitis and eczema, you wouldn't be too surprised by. Perhaps migraine in association might be of greater interest, or anything else. So do ask them if they've got any other medical problems, because you may have better modalities for something that is relatively minor. Advanced disease often is fairly featureless with not a lot of modalities. Or alternating features. I mean, I saw a patient the other day who'd had, what was it she had? Oh, he has quite bad migraine, that's right. Migraine until she got rheumatoid. Then when she got the rheumatoid, her headache went away. The alternation of migraine and rheumatoid arthritis. And then, of course, talk to the relative or the spouse. I've already given you, this one we've already mentioned, for instance, in the case of this Indian lady. And indeed, I did give her natrum mur. And in fact, all went a bit deeper, even a bit deeper than I explained, because apart from this terrible trauma of her daughter's murder, her husband had chronic renal failure and was unable to work. And the husband said to me, oh yes, she's been wonderful. It's her who's held everything together. She's the one who's been the breadwinner. She's the one who's held everything together. And indeed, she still was, desperately, but it was all coming out somewhere in the form of this pain. Again, sepia may have mass depression. Staphylis agria we'll talk about this afternoon. And then etiology, the never well since, and you have a whole range of nosodes which you can use in that kind of way. I saw give you another interesting example, youngish man in his late 20s, nasty rheumatoid arthritis, clearly did have early but aggressive rheumatoid arthritis, seropositive, 1 or 2 erosions, definite rheumatoid arthritis, quite nasty, on quite a lot of drugs. And I took the history. It had come on, I think, 2 or 3 years previously. He'd been on holiday in Corfu and came back with a terrible sore throat, dreadful sore throat. It hadn't been treated, went away spontaneously, and the rheumatoid came on pretty soon after that. More or less on spec, I gave him streptococcinum. And again, very good response, dramatically better, greatly reduced his Voltarol, and again, I'm pretty optimistic that it will resolve completely. Nosodes, we'll talk about this a little bit later. So, rather boring, the history, retaking the history. I know this is rather tedious, but I make no apology. Because I think, I sometimes call it the lost art of history taking. I think, probably in the 19th century, doctors were better at taking history. These days it's too easy to ask the patient a couple of questions and reach for, the pathology form. So let's just run through this, with some emphasis on the things that may be worth, looking at particularly. So first of all, it's not the name of the disease, but, well, of course you need to know the name of the disease, but what is the actual complaint? Is it pain or itching or whatever? You need to know exactly what the problem is. And then the history, the temporal aspects. Was the onset explosive? Very abrupt. For instance, in rheumatoid arthritis, with an abrupt onset, one would think perhaps of apis, or with a so-called flary rheumatoid, where it's subject to sudden and abrupt flare-ups. You might think of apis. with a sort of palindromic onset coming and going, you might think of something else. With particular directions of evolution, you might think of other remedies. For instance, starting in the feet and moving upwards is Leadham very often. You know, it's it sounds a bit strange, but it's not that uncommon if you ask patients, and I'm thinking particularly of my own speciality, rheumatology, but you do get patients who say, oh yes, it started in my feet and seemed to work its way upwards, feet, ankles, knees, and then sort of gradually worked its way upwards. And the pattern of evolution, I mean, migration, again, I'm thinking again of rheumatoid, but you know, have you got the migration from joint to joint, erratic migration? Have you got alternation with other illnesses? That kind of thing, the pace and pattern of the evolution. And then the precipitating factors, mental shock, and we've just talked about a case of mental shock, this Indian lady I was mentioning. Acute mental shock, you do have a variety of remedies, Ignatia, Apis, which are said to be, for acute mental shock. Apis has this rather wonderful, quaint thing in our old books, jilted at the altar. I'm not sure that happens anymore. Probably in the language of the late 20th century, it should be came home and found her husband in bed with another woman. But you get the idea, sudden shock. Actually, what is more common, I think, is chronic stress. I think one would think of perhaps a woman who's been nursing an elderly relative for a long period. And very often, of course, they stay well until the stress is off. Then mum dies or mum goes into a home or whatever. And then, of course, that's when they get ill. And of course, they get very complex, mixed feelings. In a sense, they're relieved that mum's off their hands, and then they feel guilty for feeling relieved. So it's very, complex sort of feelings. And you have a number of remedies for that sort of situation, including natrium, mure, causticum, sepia. I think perhaps the most prominent ones. Causticum, perhaps somewhat neglected in that sort of situation, but it certainly is one of the chronic mental stress remedies. Other illnesses we've mentioned, never well since, surgery, and so on. And then the local modalities. Well worth asking this, a second time, because patients are often appallingly unobservant about their own condition. And having been asked by you once at the previous consultation about these modalities, they may have focused their minds a bit and really looked at it. And I must say I'm always a bit surprised when you get patients, say with arthritis, who don't know whether cold bathing is any good. So you turn them off, tell them to go and try the frozen heat. Then don't do it again. But if it does help, then of course it's an interesting thing. Rather unusually, well, you have to, of course, assess what is normal. I mean, if it's an acute joint, then of course it is normal for an acute joint to be relieved by cold. Ice pack on an acute joint will normally help. Less usual with a chronic joint. Normally a chronic joint is relieved by heat. But you do have exceptions. Leadham again, for instance. It's a chilly patient, it's usually a chronic arthritis, and yet it is better from cold. You can have a similar thing with skins, or rather an opposite thing with skins. Itching is generally made worse by heat. But you do have one or two remedies where the itching is relieved by heat, rather unusually, and those include arsenicum album and the russes, rus toxin, rus ven, especially rus ven, where the itching is relieved by heat. Usually it's the opposite. So that's local temperature. You have, time modalities, local time modalities we're talking about, not the general ones. The weather, can they actually predict the weather? You have a number of remedies, particularly the arthritic ones, who say they're more reliable than the Met Office. Not that that's saying much, but they tell you they know when it's going to rain hours in advance. And the ones who, the exquisitely sensitive ones are Dulcamara, rhododendron, causticum, and phosphorus. Those are the really sensitive ones who can predict when it's going to rain. I have a little, actually a modality of my own little modality for Dulcamara. Pain in the knees on walking past the freezer cabinet in the supermarket. Extremely sensitive to cold. Then local pressure. Are the symptoms relieved by pressing on them or by heat? And again, you may want to sort of, in certain kinds of pain, we'll perhaps talk a bit more about this. For instance, menstrual cramps very often are relieved by heat. Some people will say that, yes, heat does help, but pressing on it or doubling up helps more. So, and that's an interesting one to distinguish actually between magphos and colosynthes. They're both relieved by heat, but magphos dramatically relieved by heat. Colosynthes somewhat relieved by heat, but more relieved by doubling up, more relieved by bending or pressing on it. Exertion, and so on. Anything else that makes a difference one way or the other. And then, I would just run through the systems, starting at the top. Headaches are, sometimes quite interesting because they can be quite, you can get quite a lot of, interesting modalities out of them. Simicifugia, for instance. I think they're possibly an underused remedy, a remedy I'm quite fond of. Has a very characteristic headache comes from the neck right up and over, usually to the eyes. They have a complaint of pain in the muscles, all the muscles, the neck deltoid, right up and over, and sometimes a funny sensation of something loose or flapping right on the apex of the head. That's the simicifugia headache. There are lots of other different kinds of headaches, but some remedies do have quite characteristic things. Upper respiratory tract, sinusitis, whatever, chest, neck and back. Food, of course, is quite a delicate area, controversial area. A lot of the patients who come to us, I think particularly the ones who tend to come to homeopaths, will say, think they've got food allergies. In fact, it's pretty clear that a lot of patients who think they have food allergies do not actually have food allergies, and very often they've been diagnosed by extremely dubious means, including pendulums and various peculiar kinds of machines. Do be a little bit cautious on that. There's only one reliable way to diagnose food allergies, and that is exclusion diets. And you need quite a long exclusion. You need at least 2 weeks and probably 3 or 4 weeks of exclusion, and then a challenge. The desires and aversions can be overplayed. I think, because they're relatively easy to deal with, people sometimes get too locked into the, or put too much weight on them. They're relatively unimportant. But you do sometimes get, funny ones. I mean, there's, only 2 or 3 remedies that really crave acid, crave pickles. In fact, they are ant-crude, hepasulf, and sepia. It's an unusual one. I mean, fat these days is very difficult because you say to most people, do you like fried things? Do you like fatty things? They say, we grill everything, which of course isn't answering the question at all. But actually, it's usually not worth the trouble of trying to work out, are they genuinely averse to it, or have they just got out of the habit of eating it because, you can't read any women's magazine these days without seeing that fat is bad for your heart. So, and then just work down, bowel, urinary, menstrual, and so on. And then finally, not quite finally, but the mentals and the generals, the reaction to illness. Now, these 2 cases I cited of these, rather tough guy types who cried with pain, the reaction to illness. Or some people, and we'll talk about this later on, get really angry when they've got pain. They get really furious, and they make colosynthes is one, nux vomica is another, and we'll be talking about both of those later on. They get irritable and bad-tempered when they're in pain, and various other ways people might react. And then, of course, the affect. The reaction to sympathy and consolation is quite a useful one, quite a sensitive one. That consolation aggravates. In other words, and that's, of course, if you say to people, "Do you like consolation?" They'll say, "What?" They don't know what you're talking about. You have to translate that into modern language. So, do you feel better for talking about things? Do you feel better for a bit of sympathy and a bit of fuss and bother, or does it irritate you? And the natrimures and the sepias certainly will be irritated and made worse by consolation, by fuss and bother. They just want to be left alone and get on with it. Others, pulsatilla and phosphorus, feel better for talking about it for a bit of comfort and sympathy. Anxiety, what's the nature of their anxiety? Is it linked to specific situations, or sort of more free-floating? Carb, for instance, has a rather free-floating anxiety. They seem to worry about almost anything and everything. They're almost looking around for things to latch onto, to worry about. And then the various specifics, tidy, untidy, assertive or giving in, and so on. I'm sure you know about that. I don't need to go. Also, phosphorus normally with a high libido, but it can swing the other way. and then high libido phosphorus, Staphylos agria, one or two others. Where are we now? So let's look at one or two, little points that are worth, few modalities. As I said earlier, my patients are sometimes appallingly unobservant about their own modalities. So it's just, just one or two little modalities that I like, that I find quite useful. Time of day. I'm not actually that sold on the arsenicum album, 1 in the morning one. But certainly this is very characteristic for Cali carb. The books will tell you that nux vomica is a bit earlier than that, 4 or 5 in the morning. My experience is they wake up in a foul mood, but at 5 or 6 in the morning is the thing. Better in the morning is very often phosphorus. Worse in the morning, which we haven't got there unfortunately, lacosis. Terrible. They're always worse after sleeping. They hate the morning. They wake up feeling groggy and bad-tempered. Quite a number of other remedies also, but very marked in lacosis. A few weather ones, worse in wet weather, natrum sarthuia, dulcamara. Better from cool, fresh air. That's quite a useful one. Pulsatilla has that quite strongly. Pulsatillas will tell you that they feel the cold, but like the fresh air. They will tell you in the winter they have 3 duvets on the bed, but the window open. That kind of thing. They feel chilly, and yet they are better from cold, fresh air. Temperature, drink, just a few things. And then associated features, just again a few things, associated with almost anything they have. Frightened. This is actually particularly thinking about asthma here. When they're very frightened, when they've got an acute attack, arsenicum album or aconite exhaustion is Cali carb. Hemoptysis, small little streaks of blood, quite often phosphorus, or nosebleeds, and just general easy bruising. Nasal polyps, and so on. And then the full house. So this is asthma, particularly sulfur and arsenicum album, I think. This is so that's just a few things. And then we mentioned these questions about the evolution, the pattern and pace of evolution. Let's just have here we're thinking particularly about arthritis. I mentioned already the so-called centripetal migration of lead, and particularly starting in the feet and working up. Calmia is said to have the opposite. Erratic migration, moving erratically from joint to joint, which in fact both these two cases that I mentioned earlier had. Pulsatilla or Calibic. Alternation with asthma, or other things, actually also alternation with migraine. Calibic is certainly one of the alternation remedies. And then examination, especially in skin complaints, but also in other things. You can get a lot out of examination. Mouth, you can pick up some interesting things on the mouth. Tooth marks all around the edge of the tongue. Merck salt. Merck salt is a very useful remedy actually for various kinds of chronic URTIs. They'll have a lot of saliva, halitosis, but look at their tongue and you'll see the marks of the tooth all around the edge. Swollen tongue. So-called geographical tongue, natrum mur, ulcers, mouth ulcers, nitric acid, particularly. There are others, but it's particularly right. And this is what the French call fanaire. The French have a word which encompasses both hair and nails. And they very often do go together. Silica has very, very characteristic. I mean, silica is one of the remedies you can sometimes diagnose just like that when you shake hands with a patient, the so-called frog handshake. Look at their nails. They've got longitudinal ridging, and they'll often tell you their nails are weak and break a lot, become weaker since they were ill. And also their hair has become finer, maybe falling out, but particularly it's gone finer. So finally, having been through all that, really, not getting anywhere, only at that stage that I then start to come down to back to what is, according to some of the homeopathic books, was a reflexive answer, which is to use a nosode or a miasmatic remedy, so-called, and I put it in inverted commas because I don't really think that at least the classical version of the miasm theory is really sustainable in the light of modern medical knowledge, but nevertheless one does use it in a sort of informal way. So you do have remedies, thuia particularly is a sort of psychotic miasmatic remedy. Or a nosode. I mean, tuberculinum, tub bob is one I use quite a lot. And very often, just because other things haven't worked and you can't quite get the picture. The tuberculinums very often like travelling. They're great travellers. Or a bowel nosode. The bowel nosodes, I think, are a very interesting and useful group of remedies, probably underused, generally selected on the basis of the associated remedies. And we did recently republish, well, not that recently now, but it has been republished, the list of the associated remedies. If you have a patient who's perhaps improved a bit on the remedy, but has not completely cleared up, and perhaps if you have some reason to think that some kind of bowel pathology may be associated, then you can use a bowel nosode. In particular, the case I particularly use it very often is ankylosing spondylitis, which is a bowel-associated, bowel flora-associated disease. Has been shown to be quite recently as one of the areas where the homeopaths were way ahead of anybody else in saying that the bowel flora can be associated with chronic disease. And indeed, you can show that in people with ankylosing spondylitis compared to matched controls, the incidence of cross-reacting antigens in their bowel flora, antigens that cross-react with intervertebral disc, is much increased. So it is related to the bowel flora, and very often they will respond to a bowel nosode. So that's a sort of quick gallop through a few things to do if you're not doing as well as you would wish to do. And I don't know if we've got time for questions, or should we perhaps take them later or what?